All right, so let's get started. So I forgot to talk about 2 drugs for ulcers that are not acid lowering. So I need to talk about those.
I know the 2 drugs, but do we need to know motion sickness drugs? Because it wasn't on our drug list, but it's in your PowerPoint.
All right, so I'll mention motion sickness drugs too.
Okay.
So I need to go over a couple drugs that I didn't include on the last lecture, so let's talk about those ever so quickly. When it comes to ulcer drugs, there are 2 ulcer drugs that are not acid lowering. And the first one is called misoprostol. And this is basically an artificial prostaglandin. So it acts locally in the stomach to increase the amount of mucus production in the stomach. Second one is sucralfate. Sucralfate is a gel that it forms a protective gel and it sticks to the ulcer, and that kind of prevents the damage from the acid occurring. The downside of sucralfate is that it can interfere with the absorption of certain vitamins and drugs.
You're talking so fast. I can't keep up with you. You're stressing me out.
Everything I'm saying is in your notes,
Okay,
so you don't have to write it every word down.
No. Verbatim.
No, I must produce a transcript of what you say.
No, because then you say something and then I forget like the main point of the one before it.
So, anyway, that's pretty much it for those 2 drugs. By the way, misoprostol is also used during labor and delivery to ripen the cervix.
Oh my goodness.
And what do we mean by ripen?
Help efface it.
Help dilation and effacement. All right. The next thing that I didn't talk about was antiemetic drugs. Motion sickness drugs as an addendum to antiemetic drugs. So motion sickness drugs are drugs that are specifically used to reduce motion sickness, and the vast majority of them are antihistamines, and it's basically the drowsiness that is causing the anti-nausea effect. So basically by suppressing your brain function a little bit, you have less vomiting. So pretty much all of them, Dramamine, Meclizine, whatever, Bonine, they're all antihistamines.
I think it was like cyclizine, meclizine, and diamond hydro.
Yep.
Those were the ones in your PowerPoint.
What else? None of them are on your test.
Oh.
You asked for it.
No, I was wondering if we had to know it because
Well,
it was on the PowerPoint.
They're helpful. I mean, we do live in Florida, and lots of people like to go on ships around here.
We don't need no motion sickness drugs.
Well, you don't for your test.
Okay.
Okay, well then we don't need to know that.
No.
So let me ask you this question. Is there such a thing as an effective non-drowsy motion sickness drug?
No.
Not really.
No.
Some of them are less drowsy, but they also typically don't work as well. All right. So, on that note, let's get started with today's lecture. And what we're going to talk about today is we are going to talk about inflammatory bowel disease, IBD. And so inflammatory bowel disease is typically 3 distinct disease processes. 2 of them are related, and the third is completely separate. So ulcerative colitis, Crohn's disease, and the last one is, don't you hate it when you have a senior moment?
We're juniors.
I'm just giving you guys a chance to catch up in your writing. No.
Oh.
Diverticulitis. Way to help me out there, guys. Now I gotta cut that out. We can't have human professors on camera. Okay. So these are the 3 diseases that make up IBD. So when a person has IBD, they typically have one of these diseases, although it is possible to have more than one at the same time. But it's not a situation like COPD where it's always a combination of 2. It's usually just one. All right, so let's talk about ulcerative colitis first. As the name implies, there's ulcers, and it occurs in the colon. You didn't see that one coming, did you?
I didn't even think of that. Yeah, I'm not reading that much into it.
The lesions are usually characterized by blood and mucus, and it's an episodic disease, which means that for much of the time, patient will have no symptoms whatsoever. And then they will have a flare or episode where they have symptoms. During a flare, patients will have large amounts of diarrhea, sometimes losing more than 6 liters of fluid a day, and having more than 16 bowel movements in a day. Things that can trigger them include infections, stress, and food. So patients need to kind of learn their triggers and then avoid them. So sometimes you'll meet a person who like, look, I can't handle this stress today because my ulcerative colitis is gonna act up. And so they like tend to avoid conflict or whatever it is that gets them stressed out. Learning which foods cause your trigger is also very important. So we're going to contrast that with Crohn's disease, which is very, very similar in that there's ulcerations of the GI tract. But in Crohn's disease, instead of being just in the colon, it can be anywhere from the lips to the anus. So you can have inflammation of the stomach, the esophagus, the mouth, or the colon. And one of the things that typically happens in Crohn's disease is that patients will have small intestine inflammation. What would you think that does to digestion?
Choking slows it.
It impairs digestion. So sometimes patients with Crohn's disease will actually kind of waste away because they can't eat enough food to maintain their current weight. When that occurs, their risk of dying goes way, way up. Patients with Crohn's disease will also be more likely to have problems with not being able to absorb enough nutrients like minerals and micronutrients. Unlike ulcerative colitis, so I guess I should just mention, so ulcerative colitis, wherever the inflammation starts in the colon, it's going to continue pretty much to the end. So if, let's say that it started right here, you're going to have continuous inflammation and ulcerations all the way down to the end. With Crohn's disease, let's say you have some here, and then you have it skips, and then you've got more, and then maybe it skips again. So this is known as skip lesion. You'll never see skip lesions in ulcerative colitis, only Crohn's disease. Crohn's disease can also have inflammatory effects on other parts of the body outside the GI tract. And then the last difference is in who tends to get it. There is a genetic component to both diseases, but ulcerative colitis tends to occur in early adulthood. So mid to late 20s, 30s, that's when people tend to get ulcerative colitis. Children tend to get Crohn's disease. So typically it's during the teenage years, but it can happen earlier. I've seen cases of 2-year-olds who have Crohn's disease, although that's relatively uncommon. It's usually like, 9, 10, and then early teens. Because of the early onset of Crohn's disease, there's a psychosocial component that is important in the disease. So what's it like to be 13? Whoa, an emotional roller coaster. And what's happening around that? What grade are people in around age 13?
7th grade.
It's like 8th grade, 7th, 8th grade. That time of your life is known as what? What part of school?
The awkward.
Middle school. And middle school is an incredibly awkward time, right? And a lot of times you go to a new school and no one knows each other, and some people are going through puberty and other people aren't, and you're self-conscious about everything, and you're just beginning to really get into fashion, and all of a sudden what you wear really matters, whereas before it didn't that much. And some of you are cute as kids and you went through puberty and what happened? Others of you, the opposite happened, and it's just an exciting time to be alive. And then you throw into that, what happens at that time? People start doing what? Dating. So now, what is the number one date activity?
Eating.
Go out to eat. Dinner and a movie. Okay. And all of a sudden, what does it do to your social life when you can't go out to eat because you have to have a bathroom handy at all times? When certain foods trigger a flare. When the stress triggers a flare in dating and stressful. So it puts a large damper on a person's social life to have Crohn's disease as they're growing up. Now, that in and of itself is not a problem. I mean, it's a problem, but it's not a huge problem developmentally, so much as the parents, the way that they deal with it. So imagine for a moment that the love of your life, the apple of your eye, is just suffering. Suffering physically, suffering socially. What would you want to do for them? Would you want to give them a talk like, hey, sweetheart, this is the way it is. You got to tough it out. You'll be a better person for it. Or might you be like, well, honey, it's okay. You don't have to do that. We'll do something nice for you instead. How would that affect a person's development? So, Crohn's disease patients have a tendency to be thought of as somewhat self-centered and needy and maybe spoiled and whiny. And it's not because of the disease itself, it's because of the way that their parents interact with them as a result of the disease. Does that make sense? So, there is a psychosocial component, but it's primarily about the developmental aspect of how parents interact with those kids. All right, so as far as the treatment of ulcerative colitis and Crohn's disease, they're somewhat similar. So the first one is behavioral. And that is learn your triggers and try and avoid them. Second is drugs. So the main drugs that are used nowadays are salicylates, which are similar to aspirin, but they're not actually aspirin, and they help to reduce inflammation in the gut. So an older drug is sulfasalazine. Now, they reduce inflammation in the gut. So sulfasalazine is one of the older drugs. As the name implies, it is a sulfa drug. So you've got the issues with sulfa allergy, and it's actually a prodrug, and it gets metabolized into something called mesalamine. Mesalamine is sometimes known by its kind of chemical nature, which is 5-ASA. Or, what's the fancy name of saying 5? More fancy than Spanish. Let's go Latin, pent. So sometimes it's called pentasa. So, 20 years ago, sulfasalazine was far more common than mesalamine because this was under patent and this was not. Nowadays, mesalamine is probably more common because it doesn't have the allergy issues. It works faster because it doesn't need to be converted, and it's generic now. So the salicylates are the first one. Then we also have steroids. You want to try and minimize the amount of steroid use because of all the adverse effects that go along with steroids. You've already learned about steroids in Patho Pharm 1. We went over them again in endocrine in this course, and now you got them again. So there's no excuse for not knowing the adverse effects. Well, I mean, I guess there is an excuse, and that's that, you're a lazy, lame person who doesn't care about their, anyway, no, there's no excuse. So, guess you should know those. And then, so a lot of times what we'll try and do is we'll try and only give steroids during a flare, but some patients will not be able to not have flares without having at least low-dose steroid. But the more steroid you give, the more likely they are to have all of those other adverse effects.
Is subsalicylate, like Baseline subsalicylate, is that like?
No.
No, not related at all?
It's related, but it's not what we mean.
Okay.
Yeah. All right. Then the last one is immunosuppressants. So some common immunosuppressants that would be used are the biologics, like Humira, and then also some of the cytotoxic drugs like azathioprine or mercaptopurine. And that is review from Patho Pharm 1 as well. What's the question there?
I don't remember learning the second one.
You didn't.
What are they? What are the names?
I was gonna say I don't know that.
Azathioprine and mercaptopurine.
Can you spell that?
Mercapto it's a newer drug than azathioprine, and it's beginning to replace azathioprine, maybe a little bit more than beginning. So sometimes I think about replacing azathioprine with it on the drug list, but I haven't gotten around to it, so bygones. Mercaptopurine will not be on your tests, but you might see patients on it. Man, Dr. You think about, you think the reaction would be, well, thank you for letting me know I don't have to study that for the test, rather than, wasted brain power! It's not wasted. You will see these drugs in patients, so. Anyway.
Just like that.
That is exactly I can see it happening in your head. All right, any questions about those drugs? Okay, those are the main drugs that are used. And then in severe cases, you can use surgery. So we got to talk about some surgical terminology. Now let's imagine for a moment that you got a colon. Let's use multicolors. All right, so there's a colon, and let's say the patient's got an area of inflammation like this. So if you snip out the inflamed portion, what's that called? It's called a resection. So to resect means to take out a section. Now, what happens now? You got two possibilities. What are your two possibilities?
Ostomy.
Okay, so one, we're going to take this to the surface, and the patient's going to have a stoma. They're going to have an ostomy. So they're going to have colon sticking out of their gut. And you have a little bag that goes around the top of it. Does that make sense? What's the other possibility? The other possibility is that you pull this down and reconnect it together. What's that called? That's called anastomosis. So sometimes when people hear resection, they think connect the two ends together. That's not what resection means. To resect is to cut out a section. What's it called when you connect the two ends together? Anastomosis. So depending on the situation, they might do an ostomy or they might do an anastomosis. Sometimes they'll do a temporary ostomy, and then after a couple months, do an anastomosis. Does that make sense?
Why would they do that?
Why would they do that? The reason is to give, they call it bowel rest. So basically they're trying to say, like, maybe you have really severe inflammation here and then mild there. So they're trying to save the mild portion. So they're basically just letting things kind of settle down before they connect them together. Because when you connect things together, what are you going to have in order to heal that spot? Inflammation. So if things are too inflamed at first, they want to let things settle out, then do the anastomosis. There are lots of YouTube videos by people who have had these types of surgeries at young ages on YouTube, and maybe I'll send you a couple.
Do you look them up in your free time?
Yes. No, actually, I looked them up in my work time.
Oh, you might want to cut that out while you're video.
Sage?
No, I was just wondering if this was for Crohn's disease as well.
Yes, Crohn's disease as well. The one big difference with Crohn's disease, instead of just being in the colon, you can also have it in the small intestine. So if you do an ostomy of the colon, we call it a colostomy. If you have it of the small intestine, it's called an ileostomy. So what's the lower part of the small intestine? The ileum. So ileostomies are typically on the right side of an abdomen, so over on this side, and they're smaller. Colostomies are typically on the left side, and they're larger. So you guys can learn all about what it's like to have one and change one and live with one and have intimate relations while you have one by watching YouTube. Hey, it's important for nurses to know this stuff. I mean, your patients are still going to have sex, right? How do you handle that thing? I don't know. Isn't it kind of awkward? Well, there's ways we can deal with that. Oh, okay. Yeah. So anyway, there you go.
Thank you for that.
All right. Any questions about ulcerative colitis or Crohn's disease? All right. Next, we have what are called diverticulitis. Now, there are two related terms here. The first one is diverticulosis versus diverticulitis. So what's the difference between diverticulosis and diverticulitis?
Itis is inflammation.
Itis is inflammation and osis is presence of. So the presence of diverticula. Diverticula. So a singular is a diverticulum, and it's an outpouching of the colon. So here you've got a pocket as an outpouching, and stuff can get trapped in there. So as that stuff gets trapped, if it becomes inflamed and infected, that's what causes diverticulitis. So what is it that causes a diverticulum in the first place? And the answer is, we don't really know. There's a genetic component, so choosing the right parents helps. And there seems to be a behavioral component as well. We want to say that you should avoid straining on the toilet, but straining in and of itself is not going to cause diverticula. So in the end, we're not really 100% sure. Once you have them, what do we do with them? You can surgically remove them, but most of the time the answer is nothing. You should eat a higher fiber diet. We used to tell people to avoid nuts because if you open one of these things up, it looks like nut residue is in there. And so by avoiding nuts and popcorn, you don't get stuff trapped in there. But where one of the largest studies was done, it's like 100,000 people were followed for 10 years. Guess what turns out? It doesn't matter. So the older, you'll still hear people say, well, you need to avoid nuts and avoid popcorn. But in fact, you don't. It made no difference whatsoever, the people who avoided them versus the people who ate them. Whew, I can still have popcorn. So once they become inflamed, all right, so what do we do? What do we do with osis? You want to maintain a diet high in fiber, and you want to basically avoid straining. Once a person's got diverticulitis, then we want to bake the patient NPO at first. And when we do reintroduce food, we want a low residue diet. What does that mean? What is residue?
Like it leaves something?
Leave something behind. What would that something behind be?
Species.
Feces. Residue is what resides after whatever else is pulled out. So the residue is feces. So what you want is a low residue diet, which means not a lot of fiber. So for itis, NPO at first, then low residue diet, and then eventually they can have full diet again. That's going to be the basics, but you also may need to administer antibiotics. So NPO and antibiotics, good hydration, that would be considered conservative therapy. What are you conserving? What would you be conserving?
The tissue.
Yeah, the colon. So what's the opposite of conservative therapy?
Radical.
Aggressive, which is going to be surgery. So in more aggressive therapy, you will resect the colon to get rid of the diverticula. Does that make sense?
This is all for itis.
This is all for itis. For osis, you don't do anything. Man, high fiber diet, avoid straining, whatever. For itis, NPO, antibiotics, hydrate, that's conservative therapy. Aggressive therapy, cut it out. Cut it out, you guys. All right, any questions about diverticulitis? Now, the last thing we have to talk about in this little area is something called IBS. Irritable bowel syndrome. Now, what is a syndrome? How is syndrome different than disease?
Isn't it caused by something else?
Well, I mean, technically everything's caused by something else. A syndrome is a collection of symptoms. So, in this case, the symptoms are typically abdominal pain, bloating, cramping, and either diarrhea or constipation. Most patients will tend towards one over the other, and some patients have a diabolical combination of both. Now, there's a movie that's kind of old now with Ben Stiller and, what's her name? Rachel from Friends. Jennifer Aniston. There's an older movie with them in it where his character has irritable bowel syndrome. And so if he eats spicy foods, he's got to go. And so there's a funny scene where he has to use the bathroom in her house and blah, blah, blah. So patients who tend towards diarrhea sometimes have like a sympathetic response. Like within half an hour to an hour after they eat, they have kind of like this sympathetic response. They might get sweaty, might be a little bit diaphoretic, and then they have diarrhea. And so that's more often men than it is women. And with IBS in general, more women have it than men. So women tend towards the constipation side of things where they have constipation. So the key thing behind irritable bowel syndrome as opposed to inflammatory bowel disease is that there's no disease tissue in IBS. So if you do a colonoscopy What does the colon look like? Completely normal. So it is called a functional illness. What does that mean? What is a functional illness?
But the tissues don't function properly.
You don't like the way your body functions. Your complaint is, I feel bloated, I've got pain, I've got constipation, I've got diarrhea, I can't eat whatever kind of food without having to have diarrhea. That is a functional illness. You don't like the way your body functions. But when we do the tests, as it turns out, there's no disease. So here's a case where you have these symptoms you don't like, your life is impacted by it, but you're completely fine. No, I'm not fine. My body ain't working right. So what do you do about it?
Treat the symptoms.
You treat the symptoms. So there are some drugs you can take that will, if you've got constipation-based IBS, make you go more often. If you've got cramping-based, you can use something like Bentyl or dicyclamine. If you've got diarrhea-based, you can take drugs that will reduce your diarrhea. A lot of it has to do with finding your triggers. So if you know that spicy foods do it, maybe you avoid spicy foods. Or planning around it. So, well, we're going to have to go to the dinner a little bit early so that we have a chance to stop and go to the bathroom before the movie. You know, basically work around it. So lifestyle modifications is the #1 treatment for IBS. And then you can treat the symptoms with drugs. All right, any questions about IBS? All right, on that note, we're going to be done with IBS. Woohoo! So we're done with the digestive tract. How do you feel about that? I feel pretty good. Now we're going to do accessory organs. So what are the accessory organs of the GI system? Liver, gallbladder, pancreas. So we're going to start with liver, the big one. Is the liver the biggest organ in your body? No? What is?
Skin.
Skin. So liver is the largest solid organ in your body because skin ain't that solid. It's kind of stretched all over the place. What's the liver's job? What's his main job? There are 2 of them. So main job #1, filter blood. What does it do with what it filters? Oh, come on. You guys know the answers here. You're just pretending like you don't. Say again?
What's the question?
What does your liver do with what it filters? Think alcohol.
Breaks it down.
It metabolizes it. So it's going to filter the blood and then metabolize the stuff in it, including drugs. What was that? That is part of what the first pass effect is, yes. So, do you remember from Patho Pharm 1 the series of enzymes that are present in the liver that do this? No, I was scarred.
CYP.
Yeah, cytochrome P450 or CYP. Whew. Okay, so that's one of the liver's main jobs. What's another main job of the liver? So it breaks stuff down. What else does it do? It makes stuff. And I heard someone say proteins. So proteins are one of the things it makes. Name 5. I can't even name one.
Albumin.
Okay, albumin, got one. Give me another one. Okay, it makes bile, but that's not protein, that's stuff. So yeah, we will talk about that in a moment. So, albumin was one. Give me another one. Fibrinogen. All right, give me another one. Angiotensinogen. Mannose binding lectin, CRP. I got no idea what those things are. Very sad. All right, so it makes stuff. Now, the last, and then it also makes other things, like it makes triglycerides, it also makes glycogen, it stores glycogen, things like that. And then the third one, and it makes bile. Now, there's a few components of bile, but what gives bile its name? Bilirubin. And what is bilirubin? I don't know. When have we looked at bilirubin in the past, in Patho Pharm 1, test 5? What was test 5? It was hemoglobin and clotting. The breakdown product of hemoglobin eventually is bilirubin. Oh yeah, so if you're destroying red blood cells, bilirubin levels will go up, right? Okay, so bilirubin is going to be conjugated by your liver. So you've got what they call direct bilirubin and indirect bilirubin. So direct bilirubin is conjugated by your liver, ready to be excreted in your bile. Indirect bilirubin is the raw stuff that comes out of red blood cells. So, in order to get rid of bilirubin, what does your liver have to do? Conjugate the bilirubin. What's conjugated bilirubin? What's the other name for it? Direct. And what's the name for unconjugated? Indirect. So it's the same. In, un, and then with no prefix, direct, and conjugated. So, if you have elevated bilirubin, one possibility is you're making more of it than usual. What would that be an indication of?
Red blood cell destruction.
Red blood cell destruction. What's the fancy name for that? Hemolytic anemia. Another possibility is that your liver is not conjugating it correctly. That can happen during liver failure or other liver dysfunction. The third possibility is it's conjugating it, but it's not being excreted properly in the bilirubin. And that could be because either the liver isn't excreting it or there's a bile blockage.
It's not being excreted properly in the bile, you mean, right?
Yes. You also have bilirubin present in your feces, by the way. Because where does the bile go? Think about it. Where does bile go? In the digestive tract. And so the bilirubin gets excreted. That's what makes your feces kind of brownish reddish color. Without the bilirubin, feces are gray. They call it clay colored, but one of the problems with clay is that in some places clay is gray, and other places clay is red. So which one is it? Gray. So that's typically, like if you go into pediatric nursing, if they've got gray colored stools, that's a sign that bilirubin is not being produced. So it's a biliary obstruction. Does that make sense? Okay. So, what are the three possibilities for why you have high bilirubin? Hemolytic anemia, liver not conjugating,
And it's not being excreted.
and not being excreted in the bile. So, when it comes to evaluating the function of the liver, bilirubin is an important part of that. Now, if you've got high indirect bilirubin and the blood counts are normal, what's the most likely problem? The liver what? The liver is failing to conjugate the bilirubin. If you've got normal CBC and you've got the total is high and the direct is low, what does that tell you? What does direct mean? It's been conjugated. So if conjugated is low, but the total bilirubin is high, what kind of bilirubin is high?
Is it not being excreted?
The conjugated is high, so it's not being excreted properly.
You just said the conjugated is low.
Sorry, yeah, I said that wrong. Let's erase that. Okay, I'll do it on the board for myself. You can follow along. So your total bilirubin is high. And your direct is low. What does that tell us?
It's not being conjugated.
It's not being conjugated. The problem is
Liver.
the liver what? Is failing to conjugate. Now, if they're both high, total and direct, what does that tell us?
That it's not being excreted.
That is not being excreted properly. And this is assuming that the CBC is normal. If your CBC is low, the blood counts are low, then we're going to assume it's hemolytic anemia. Does that make sense? All right. So when we evaluate the liver function, one of the things we're going to evaluate is bilirubin. All right. Now, let's go back up here to metabolize stuff. As the liver metabolizes stuff, what's going to build up in the liver? Waste products. Now, what's the fancy name for a waste product of metabolism?
Oh, the
Metabolites.
Yeah.
So, metabolism leads to metabolites. And because it's occurring in the liver, where do the metabolites build up? In the liver. If a metabolite is toxic, what happens?
Damage the liver.
The liver can become damaged. How would we know if the liver is being damaged?
Who aren't the yellow eyes?
The what?
Like, wouldn't you have jaundice and stuff like that?
Way late. That's
Gray stool.
jaundice is increased bilirubin. That's a way late sign.
Gray stool.
Nope. Let me ask you this question. If your heart is being damaged, how would you know?
The cells are pouring
The cells are leaking their stuff out. What stuff do we check?
Enzymes.
Enzymes, cardiac enzymes like troponin. Well,
Hepatic enzymes.
liver enzymes. What are the liver enzymes that we would check? AST and ALT. I did that one backwards. It's usually AST first, then ALT. Sometimes you'll see SGPT and SGOT. Those are older names for AST and ALT. So when those enzymes are elevated, that is a sign of liver inflammation, which means damage is occurring to the liver. Very common in alcoholism, very common in hepatitis, and very common with drug-induced inflammation. Which is why you want to check AST and ALT with patients who are taking statins. All right. So in terms of liver function, we've got bilirubin levels, we've got enzymes, and then we have something else, which is stuff that it makes. And the main stuff it makes is albumin in terms of protein. So if albumin levels are low, what does that tell us?
The liver is not functioning properly.
The liver is not making proteins properly. And that could be because of two potential problems. What are they? What do we make proteins from?
Metabolites. I don't know. No.
Where do we make proteins from? Oh, come on. You haven't forgotten your principles of chemistry that fast.
It's been a while.
We never learned it.
Transcription, translation, ribosome, stuff like
Oh,
that.
the amino acid.
Yeah, all of that is involved, but I'm just really thinking like, what's the building blocks of proteins?
Polypeptide.
Say it again. Amino acids. Right, and where do we get amino acids from?
Her diet.
Food. Oh, right. So one problem if you're not making enough protein is you might not have enough amino acids because you're not eating enough protein. So protein poor diet may be a cause. What's the other big cause?
You're not breaking down protein.
Okay, so sure. So either you're not eating it or you're not absorbing it. But now on the inside, what's the other big reason why we don't have enough albumin?
Liver.
Liver what?
Damage.
Liver failure. So liver is failing to produce albumin. So this is usually a fairly late sign of liver failure. It's not going to occur for a while. Now, most of the liver failure in the United States is not acute liver failure, it's chronic liver failure. So it's going to take, 10, 20 years to develop. So you're not going to see low albumin for 10 to 20, 30 years. When will you see the liver inflammation? Early on.
So do you look for the inflammation or for the enzymes?
You look for inflammation by looking at enzymes. The enzymes are a sign of inflammation. Yeah. All right, so now that we've discussed what the liver does and how we evaluate some of the labs,
Question. You said that the chronic takes like years to find it, but for the inflammation, how long did you say that you would start creating those enzymes to show that?
it depends on the source of the inflammation. So if your source of inflammation is, say, hepatitis C, pretty early on. If it's alcohol, it might take a while. If it's drugs, it could be immediate. So it just depends. All right, so let's talk about what happens when you have inflammation. Or no, it's not. Let's talk about the sources. So first of all, hepatitis. The number one thing when a person has elevated liver enzymes, AST, ALT, is we've got to see if they've got hepatitis. Why is that? What's the number one cause of liver failure in the United States? Not alcohol. Hep C. Now, can we treat Hep C? Ah, so if they have Hep C and we treat it, what will that do to their risk for liver failure? Decrease. What's the number one cause of liver cancer in the United States? Hep C. What will it do to the risk of liver cancer? It'll lower it. So that's why it's so important that when a patient has elevated liver enzymes, first thing we want to think is, could this be hepatitis? Now, if we just put them on a medication that can damage the liver, and they were normal before the drug and now they're not, we don't have to check for Hep C. But if there's no changes to their drugs that they've been on something that can damage the liver, they just happen to have elevated liver enzymes, what's the first thing we have to do? Check for Hep C. Well, just hepatitis in general. So 3 main types of hepatitis. What are they? A, B, and C. There are others. We're not going to talk about them in this class because they're even more rare. So just reviewing back from Patho Pharm 1, you need to know, is there an effective enzyme? Is there an effective immunization? What is the route of infection? What is the pattern of disease? And how is it treated? So for Hep A, what do you got?
There's a vaccine.
There is a vaccine. What's the pattern of it? What is the route of infection? Fecal-oral. What is the course of infection? It's acute only, and then the patient either dies or gets better. General time frame is about 2 to 3 months. Hep B, is there a vaccine? Yes. What's the route? It is bloodborne, but the number one route of transmission is sexual contact. It is a sexually transmitted infection, and also a bloodborne infection. What is the time course? Okay, so most of the time it's going to be an acute illness. Takes 2 to 3 months to recover, and about 10% of patients will go on to become chronic.
What's the Hep A is how long
Hep A is 2 to 3 months
to recover?
to recover.
But it's an acute illness.
Yes.
Do they go chronic?
No, Hep A is not a chronic. Hep B can be chronic about 10% of the time if the if the Hep B is contracted from the mother during delivery, the chances that the baby will become chronic skyrocket. And that's why we give immunizations to infants, although it doesn't necessarily make sense in the United States where we don't have endemic Hep B. In the Asian Pacific countries, like the Asian Rim countries, Pacific Rim, that's where there's a much, much higher rate of Hep B infection in the country, in those areas. So there it makes a lot more sense. All right, Hep C. Is there an effective immunization? No. What's the route of transmission? Primarily blood contact. Possibly from sexual contact, but primarily blood contact. What is the pattern of infection? The time course. It's 99% chronic. Patients will sometimes have an acute onset illness, but it's relatively mild compared to Hep A and Hep B. So instead of several months, it's usually just a week. So a lot of times patients will think they had a flu, and in reality it was their acute Hep C. As far as treatments go, in the old days it was interferon plus ribavirin, but the big problem with that was risk for depression. Nowadays we have newer drugs like sofosbuvir, Sovaldi, and those newer drugs, instead of having to treat the patient for 6 months to a year, we treat them from 8 to 12 weeks, so 2 to 3 months, and the cure rate is much higher. The reduction in viral load is sustained through time, so after they stop the drug, their viral counts stay low for a long period of time, and much less risk of adverse effects. All right, any questions about the hepatitis patterns?
I just want to know the old treatment again.
Oh, interferon plus ribavirin.
And what's the new one?
Sovaldi. That's the brand name. The generic is like sofosbuvir. Something like that. Yeah. There are other newer drugs as well. That's just the one that's coming to my brain. So now, as far as testing for hepatitis, the first thing we typically look for is immunoglobulins. So you can have Hep B or Hep C. antibodies. And those are typically, now they'll call them AB. And those can occur in either what's called surface or core. Surface is on the outside of the virus, core is on the inside of the virus. My contacts are killing me for some reason. So if it looks like I'm winking at you, it's just the pain of the contact lens.
Getting mixed signals there for a second. Just
Yeah, I might need to pause for a moment.
Do you have eye
Eye
drops?
drop in.
I don't have eye drops.
You don't have eye drops? That's kind of gross, but. Want to put water in it?
No thanks. That burns. All right, so let's take a quick break. About 2 minutes. I'll be right, or if you have 5 minutes, we'll take a break. We'll be back in a moment.
in this commercial break.
That smells so spicy.
Okay. That'll teach it to hurt my eye. Don't get old.
I have old people diseases.
When I was your age, I had 20/10 vision. Now, not so much.
Hello. I'm in class.
Why did they tell you not to eat seafood with
Say it?
colitis? My GI told me I'm not allowed to eat seafood.
It's my backpack.
Is that like a thing?
How exciting.
Sure.
I'll see you.
Are you allergic?
after.
No, I just have ulcerative colitis.
Yeah,
But
maybe.
I don't understand how that relates. Then they
No,
did
I
tell
told
me
you
nuts
it's not going to come through once.
and seeds. Stupid people.
Yes.
Yeah.
I'm filling out an application as we speak.
Yeah, I don't know.
Sorry, can't help you there.
Seafood definitely hurts.
Yeah.
I'm gonna stay away from it. But she was like, yeah, everybody that has that can't have seafood. I was like, all right. But I like seafood.
Choice is yours.
I know. I had sushi the other day, and it was bad. It's fine. I enjoyed
Yeah.
it in the moment. I'm sorry, where is everybody? I'm sleepy.
Say again?
Benzos or sedative and non?
Yes.
Okay.
Question.
Mm-hmm.
So when treating H. pylori bacteria, you said that there's only 2 or 3 antibiotics to treat, right? So because there's 2 components of Pepto-Bismol, would you include those 2 components separately?
No. The antibiotics are going to be amoxicillin, tetracycline, and clarithromycin.
And it's a metronidazole.
What? Yeah, I can give that too, but yeah, for H. pylori. So Shelby, what color is your natural hair color?
Red.
Are those highlights?
I did balayage.
Okay.
There's a couple highlights.
Yeah. All right, just checking.
Does it look good?
It looks fantastic. I know the right answer to that question. Yeah. All right, are we all back?
No.
You're like, I am back, but not mentally or emotionally. All right. So, with the hepatitis antibodies, you can look for either surface or core, and that will have either a little S for surface or a C for core. Then, if those are positive, then what you can do is, let's say that it's positive for Hep C and it's negative for Hep B. Then the next thing you can do is look for Hep C core and surface antigens. So antibodies, AB, antigens, AG. If the antigens are present, what does that tell you?
Wait, so
If antigens are present, what does that tell you? They've got it in their body right now. They have virus inside of them. So the antibodies tell us has the immune system reacted against it. The antigens will tell us if there are current viruses inside the patient right this moment. Now, in addition to that, you can also do what's called viral load. What does viral load tell us?
the amount of virus in a certain
The number of viruses that are present. And viral load is the primary target of drug therapy. What is the goal of drug therapy? To reduce viral load, hopefully down to 0. All right, any questions about hepatitis? Now, other causes of hepatitis that we need to mention, we talked about drugs. So if they have inflammation from drugs, what should we do? So liver inflammation, AST, LT are elevated. If it's from drugs, what should we do, if possible?
Lower the dose.
Lower the dose or take them off the drug. Another common cause is alcohol. What should we do there? Encourage alcohol cessation. This is not a course about addiction, but we do need to mention addiction ever so quickly. So what are the 2 main paradigms, ways of thinking about addiction?
It's a disease.
It's a disease, or
It's a learned pattern of behavior.
it's not a disease. So what's interesting is that belief in the disease model of alcoholism is actually associated with increased recidivism. What does that mean? What is recidivism? Failing treatment, going back to drinking. If you believe that you have no control over it, it's a disease and it has you, well, if you drink, was it your fault? You couldn't help it. It's a disease. Whereas if you believe that it's a behavior that you can control, you're more likely to actually control it. So what were the three components of the modern addiction theory?
Learned behavior.
Okay, learned pattern of deep behavior,
Exaggerated now.
exaggerated sense of now, decreased future. And the third one, ego fatigue. I think in the video I called it executive fatigue.
Yeah.
And that's where you just get tired of making decisions. And so the best way to help yourself there is to change your environment so that you don't have to be saying no all the time. So If you drink only in social situations, what do you need to do? Change the type of social situations you put yourself in. If you only drink when you're around certain people, what do you need to do?
Stop hanging out with them.
Avoid those certain people. But it's my wife. Well, yeah. So that's the idea behind ego fatigue. And so we're not going to go into alcohol treatment other than to say that it is possible. We did talk about detoxing from alcohol when we talked about benzodiazepines. And so you've got the stages of withdrawal. I don't think that's on your test, but it might be worth knowing the stages of withdrawal. For life, you know. And how do we reduce the risk of delirium tremens?
Librium?
What is Librium?
That's benzo?
It's a benzodiazepine. So Librium is often used for it, chlordiazepoxide, but it could be any, not any, but it could be any of the benzos that are used for that sort of thing. So it could be Ativan or diazepam as well. All right, so that's alcohol. Now, what is the number one cause of liver inflammation in the United States?
Hep.
Nope, it's not hep.
Alcohol?
It's not alcohol. It's steatosis, which is another way of saying fatty liver. It's also called non-alcohol related liver inflammation.
That's number one cause for inflammation.
Number one cause of liver inflammation in the United States. And what causes fatty liver? You'll never guess. Obesity. Being a fatty person. As a former fatty person, I can say that. You know, today's modern, you can't fat shame, you can't body shame. Well, okay, we shouldn't shame anyone. But saying, hey, look, you're overweight, it's going to impact your health, you'd be a healthier person if you lost weight, that is not body shaming. Telling, you know, even acknowledging that, hey, you might look better if you lost some weight too, that's not body shaming. Now, in telling this to a group of young girls, I do understand that there's some risk of eating disorder and all that, but the vast majority of people, even with eating disorders, tend to be more overweight than underweight. So, how do we reduce the risk of steatosis?
Losing weight.
Maintain a normal, healthy body weight. So, if the person is overweight, what should they do? Reduce weight. What's the best way to do that? What are the three major components?
Calorie restriction.
Calorie restriction,
Increased protein.
increased protein, and weight or resistance exercise. You guys are so smart. All right. So that's the steatosis. All right, now what we're going to do is we're going to skip ahead 20 years into the future when the person has liver failure. And we're going to talk about liver failure. Now, as we replace normal functioning tissue with scar tissue, we're going to end up in what's known as cirrhosis. Cirrhosis is a scarred, small liver. So, an inflamed liver is big. Eventually it becomes small and scarred. What's that called? Cirrhosis. Because the normal functioning tissue has been replaced with scar tissue, it's going to be harder to push blood through the liver. So, what is the vein that goes into the liver for filtering? The portal hepatic vein. If it's harder to push blood through, what's going to happen to the pressure inside the portal vein? It's going to increase. So portal hypertension, increased pressure inside the portal vein. Now your body's going to try and do something to get rid of that excess pressure. So it's going to start growing collateral veins.
Hyper.
Hypo. So hypertension. Yes. Portal hypertension.
Yeah.
So the pressure in the portal vein is going to be elevated. What is that going to do to the flow of fluid in that area? Going back to fluid physiology. Hydrostatic pressure, osmotic pressure, stuff happens on the arterial venous side. Do you remember all that stuff from Patho Pharm 1?
Yeah, what are you asking though? You said with the collateral?
So, well, we'll hold off on the collateral for a moment. So, you've got a liver, and you got a portal vein going into it, and we've increased the pressure inside it. What's going to do? What's going to do? What's going to happen? Well, what's going to happen? Likely. Why is there more pressure in here? Because there's more blood volume. So what does that excess blood volume have a tendency to do? Ooze out. Right. Okay. So at the same time, your patient is going to have lower albumin. What is albumin primarily responsible for in this situation, in this context? Plasma-osmotic pressure. So we have an increased desire to push blood out. We also have a decreased osmotic pressure to pull fluid back in. So what's going to happen is we're going to get an accumulation of fluid on the outside of the portal vein. So we're going to have a collection of fluid where? In the abdomen. And what's that called? So these two things lead to ascites. In your notes, I've given you a couple pictures of ascites that are like massive, like huge amounts of ascites. Now the ascites is going to put pressure on your abdomen. And your body wants to relieve this excess pressure of both the ascites and the portal hypertension. So it's going to start to grow new veins that go around the liver. What's that called? When you grow veins or circulation around something? Collateral circulation. So there's three basic places we can go to get away from the ascites. One is the surface of the abdomen. So we're going to grow large veins on the surface of the abdomen, and that is known as caput medusa. And I've given you a nice picture of Medusa in case you haven't read Percy Jackson and the Olympians. You can tell we've got a literary genius here. Yeah. So that is one place, caput medusa. Why is it called caput medusa?
Because it's like tangled.
Because the tangled veins on the surface look kind of like snakes, so head of Medusa. Another place it can go is inside. So where inside could we go? Inside the body. Where's a tube that's available? The esophagus. So that's going to be called esophageal varices. So varices, plural for varix, or varicose vein. So varicose veins inside the esophagus. Now, those are at higher risk of rupturing. Every time you eat, they're going to be scraped by the food. If they rupture, the chances the patient will die are very high. And what will the main symptom be, or sign?
Coughing up blood.
More than coughing up blood, vomiting up blood. And it's kind of like a horror movie, yeah. So there was a patient once who vomited inside an elevator. And elevators sometimes have mirrors on them. Yeah, the entire inside of the is just like coated in blood. Yeah. So now, what's the ordinary treatment for bleeding? How do we stop bleeding under ordinary circumstances? Apply pressure. How do we apply pressure to the esophagus? We're going to have them swallow a balloon and then pump up the balloon. And that's called a Blakemore.
A what?
A Blakemore. It's not going to be part of your test, but,
That's cool though. So it's
you know. No, why do you tell us these things?
It's confusing because it's like, which part is, which part is, you know?
Well, when I tell you that's not part of your test, then that's not part of your test. Otherwise, it's fair game. So, what do we do for esophageal varices when they rupture? Blakemore, which is swallowing a balloon, and that applies pressure to the inside. But extremely life-threatening when rupture. The third place that we can go is a tube on the other end. So hemorrhoids. So the three collateral vein locations: surface of the abdomen, caput medusa, inside the esophagus, esophageal varices, and then the rectum, varicose veins.
So, you might not have the time to answer this, okay, so why do people get hemorrhoids on like when they give birth?
Hemorrhoids when giving birth is because of straining.
Okay, this is different.
Yeah.
Hemorrhoids, okay.
Yeah, well, it's still a hemorrhoid, but a different reason.
Different reason.
Yeah. These hemorrhoids are caused by the need for collateral circulation. Now, if you're building all these collateral veins, that should resolve the portal hypertension, right? Say right.
Right.
Right, but it doesn't. And the reason it doesn't is because of something called splanchnic artery dilation.
What doesn't it do? It doesn't reduce the portal hypertension?
It doesn't reduce the portal hypertension because of something called splanchnic artery dilation. Now, splanchnic is a fancy way of saying gut. So the gut arteries dilate, and the reason for that is because of the problem with metabolizing. Because the liver isn't filtering blood properly and it's not metabolizing properly, there are breakdown products that aren't being broken down, and some of those products cause dilation, particularly of the gut arteries. That is going to do two things. One is it's going to lower the patient's blood pressure. Second is it's going to increase portal volume. What does increased portal volume do to blood pressure in the portal vein? It's going to increase it. So that's the driving factor behind that portal hypertension, and it's why it doesn't resolve with your collateral veins. Now, your patient's got low albumin. What does that do to your osmotic pressure? Decreases it. What does that do to your blood volume? It's going to decrease your blood volume through edema and ascites. So your patient has low blood pressure and low blood volume, but they have fluid overload in their lower limbs and in their gut. But what's their blood pressure? Low. So they've got fluid overload, it's just in the wrong place. Where does it need to be? It needs to be in your arteries, but where is it instead? The portal vein, edema, and ascites. Because of that, they're going to be wanting to retain fluid. So they're going to have, I'm running out of space here. They're going to have elevated renin-angiotensin-aldosterone activation. What's the purpose of the renin-angiotensin-aldosterone activation in this case? To maintain blood pressure. Now, if you give them an ACE inhibitor, you're going to bottom out their blood pressure, so we don't do that. But what we will do is we'll give an anti-aldosterone, either aldactone or eplerenone. And that will help to reduce some of the low blood pressure. Well, sorry, it'll help to reduce some of the fluid retention. Yeah, it'll help to reduce some of that fluid retention. The other thing that we can also do is we can give a beta blocker. And the reason for the beta blocker is that it will help to reduce the amount of renin-angiotensin aldosterone activation. Because what is it that tells your body to your kidneys to release renin?
Lack of blood flow.
Okay, so one is lack of blood flow, and the other is epinephrine. So giving beta blockers can also help. All right. The other thing that tends to happen is we have elevated levels of ammonia. So under ordinary circumstances, when your body metabolizes proteins, it releases ammonia. The ammonia is toxic to your body, so we've got to do something with it. And that something is your liver turns it into urea nitrogen. And you know that as BUN. And then BUN gets excreted in your kidneys.
It gets turned into urea what?
Urea nitrogen, which you know as BUN, blood urea nitrogen. Oh, right. And then BUN is excreted by your kidneys. It's why we call urine urine, because it's got urea in it. So, what is the breakdown product of protein metabolism? Ammonia. What does our liver do with it? Turns it into urea, which is excreted by your kidneys. But when you have liver failure, what happens to the ammonia? It stays ammonia. More of it does anyway. And that leads to hepatic encephalopathy. So patients will be confused. They can have ataxia and they can have coordination problems. And one of the signs of it is called asterixis. So in asterixis, what you do is you ask them to hold their hands out with their fingers pointing up, and their hands will flap. What's that called? Asterixis. Aster, ix, is. Eating high protein meals will increase ammonia levels. So it's very, very common after certain holidays to have people coming in admitted with encephalopathy. Can you name the #1 culprit? Thanksgiving, Turkey Day. So you can have some turkey, you just can't have as much turkey as you want. But you might as well not have any then. Yeah, whatever floats your boat. It's your life. Now, when a person's got elevated ammonia levels, we can reduce them with lactulose. So remember last class we talked about lactulose briefly, and we said it was what kind of laxative? Osmotic. An osmotic laxative. And what it does is it draws ammonia into the gut, and then you poop it out. So the treatment for elevated ammonia levels, encephalopathy, is going to be lactulose. And then what you want to do is want to make sure that they poop it out before it can be reabsorbed. So the way that we're going to do that is lactulose plus tap water enemas. Basically flush out the colon.
They said that you could use enemas to treat constipation too?
Yes, you can use enemas to treat.
What is it?
An enema is when you put liquid into the colon.
Oh.
So there's different types of enemas, but the usual use of an enema is to cause evacuation of the bowels. So in this case, we're going to make them get rid of it before they have a chance to reabsorb any ammonia. So typically the order will be something like lactulose however many times a day and tap water enemas until clear. Better off just not eating that turkey if you ask me.
Why don't you want lactulose to stay in your? Why don't you want it to digest? I'm sorry.
No, the lactulose will get pooped out. But it'll draw ammonia into the gut, and you want to make sure that ammonia gets excreted and not reabsorbed. So the way you do that,
Yeah. So it doesn't cause reabsorption.
Right.
Chill. Sounds good.
okay. I feel like there's something else I'm missing on the liver thing. So, am I missing anything from your slide? You're supposed to look at your slide.
Oh, I thought he was asking me.
Allergy,
Specific, portovein, etiology, posthepatic, prehepatic, splenomegaly, blood Bexa, ascites, hepatic, and so.
I think I got it.
I think you did.
All right. So,
Oh, that's
Your-
fine.
your patient will typically have like these really big legs, like big tree trunk legs because of edema, and then a big belly, and then everything else is little. When a person has ascites, if they've got too much ascites, you can treat that by removing the fluid, and that's called paracentesis. So paracentesis, you're basically sticking a needle into their abdomen and letting water come out. I've seen them take 20 liters off of a person in one day. So, how many gallons is 20 liters? Well, how many quarts is that? It's about 44 quarts. How many quarts are in a gallon? 4. That's 11 gallons of fluid in their abdomen. How many have ever carried a 5-gallon bucket? Pretty heavy, right? Mm-hmm. Yeah. Okay, so,
The
yeah.
next day, it fills right back up again. A lot of it. It does on occasion.
Yeah. Now, one of the things you have to be careful about when you do paracentesis is that fluid is compressing their arteries. So it's helping to raise their blood pressure. And if you take it off too quickly, their blood pressure can drop. When they get into this state, really there's only one true treatment, and that's a liver transplant. In order to be eligible for liver transplant, they have to not do any drugs or alcohol for I don't know how many years, but doing that will take you off the list. And I've got a video that I'm supposed to show you, but this particular room doesn't have good video capabilities, so if you ask nicely, maybe I'll post it on YouTube, on what's it called? On Canvas. I don't have it on that computer. Yeah. All right. Any questions about liver failure? Portal hypertension. Do you need another break?
I feel like I need another break. But I want to get. We want to get done.
I want to be done.
Yeah, sure.
How much more do we have for?
For GI?
Yeah.
We've got probably another 15 minutes of GI.
Okay.
And then we'll
do
take a
that,
break.
And then we'll take a break. Sounds good.
All right. So next, we're going to move on to gallbladder.
Is it as rough as liver?
No. It's not as complicated as liver. All right. So we're going to draw things not to scale. So here's your liver, and then there's a little duct, and then there's a bag. And that bag is full of bile. What's the bag's name? The gallbladder. So what's another name for bile? Gall. Oh,
really?
right, yeah. Pfft, duh. And there's another name for bile as well, and that's cholera.
Oh, correct.
So sometimes the gallbladder is known as the cholecyst, which means bile bag. And what's a bladder? A bag.
Bag.
A bag. So bile bag, bag of bladder, gallbladder, it's all the same thing. So it's produced in your liver and then secreted through a number of biliary ducts into the gallbladder. Your gallbladder stores it until you eat a meal and then squirt some of it into the intestine. Does that make sense? Okay. Now, there's a common duct with the pancreas, which kind of swims all in and around here. So it's called the common bile duct. The common bile duct is shared with what other organ? The pancreas. So when you have an obstruction of the common bile duct, that also leads to an obstruction of the pancreas. The number one problem that happens with the gallbladder is inflammation, cholecystitis. The number one cause of cholecystitis in turn is gallstones. So what are the two major influences for cholecystitis? The number one is obesity. And the number two is alcohol, chronic alcohol in particular.
Is it,
So cholecystitis is gallstone?
In men, alcoholism is more common cause, and in women, obesity is more common cause. The classic pattern is a middle-aged, overweight female. However, you can also get it when you're young. And usually in a room this size, there is at least one woman who's had it by the time she's 20, 22 years old, who's not necessarily overweight. And I see a head nodding. So, yeah, almost always is at least one person who's had cholecystitis that requires a cholecystectomy. So as far as treatment goes, we can have either conservative therapy, which is going to be keep the patient NPO, lose weight, reduce alcohol consumption, and then we've got aggressive therapy, which is going to be cut it out. And what's the fancy name for cutting it out? Cholecystectomy. Now, what is the purpose of bile in the first place?
Can you repeat the question?
What is the purpose of bile in the first place?
To help break down foods.
To help what foods? What type of food in particular? Emulsify fats. So, bile is involved in the absorption of fats. When you don't have a gallbladder anymore because you cut it out, you don't have this nice little bolus of bile. Instead, you have kind of this small constant drip of bile. So for some patients, if they eat high-fat meal, that will result in fats not being emulsified and absorbed. So when it's not absorbed, what does it do? Comes out the other end. And that's known as steatorrhea, or fatty diarrhea. And it's the 3 F's: frothy, foul-smelling, and floating. Frothy, foul-smelling, and floating. Yum. So, generally speaking, patients who have a cholecystectomy should avoid large high-fat meals. Some patients will say, but it doesn't matter to me. I can eat whatever I want. I don't have any problems. And you say to that person, Well, I'm glad that it works for you. But that doesn't mean it works for every patient. Does that make sense? All right, any questions about gallbladder? All right, next we have pancreas. So, with pancreas, the two things that we worry about is pancreatitis and pancreatitis. So the first one is acute and the second one is chronic. So for acute pancreatitis, usually what happens is we have a blockage of the common bile duct, which is going to lead to a backup of digestive enzymes. What are the two main enzymes that are types of enzymes that are released by the pancreas?
Digestive.
Okay. Amylase and lipase. Now, what are your cell membranes made of? A phospholipid bilayer. Yeah, you guys like.
The hydrophilic cell and a hydrophobic core.
All right, so phospholipid bilayer. And what do you think lipase does to cell membranes?
Break it down.
It digests them. So when the digestive enzymes can't get down that tract and they back up into the pancreas, what does it do to the pancreas?
Starts breaking it down.
It auto-digests. So acute pancreatitis is associated with auto-digestion. So we learned when we talked about cholesterol that elevated triglycerides are associated with increased risk of pancreatitis. Gallstones are also associated with elevated risk of pancreatitis. And alcoholism is also associated with the increased risk of pancreatitis. I know.
Note, everybody. Sure does.
Gallstones, increased triglycerides, and alcohol.
Yep.
What do you
I felt so good when I walked in here this morning because I knew everything that we did from last class, and now I feel so bad.
So when are pancreatic enzymes released? When a person eats. So the pain will typically be worse when a person eats. So in terms of treating acute pancreatitis, what do you think we need to do? Okay, keep the patient in PO and pain management. Treating the pain is the number one most important thing. And how are we going to treat the pain? Keep the patient in PO and
Give them pain medication.
Dilaudid, morphine. So yeah, opioid drugs. Then there's a number of other things you need to do, including treating the underlying cause. But the most important thing, keep them in PO, treat the pain.
So if they're MPO, does that then mean that they're TPN? Or
Well, yeah, you're going to put them on TPN. All right. The next thing we have to worry about with pancreatitis is chronic pancreatitis. Now, what was the key word with acute? What's the disease process? No, what's the disease process?
Backup of digestion.
Yes, the backup of stuff causes autodigestion. So the pancreas is like eating itself. In the case of chronic pancreatitis, that is not what happens. In chronic pancreatitis, we have a replacement of parenchyma. What's parenchyma mean? Functional tissue with what? Fibrotic tissue, which is a fancy way of saying scar tissue. The driving factor for chronic pancreatitis is chronic inflammation. That can be from a number of things. It can be from alcohol. It can be from gallstones. It can be from cystic fibrosis. Those are kind of the big three. But whatever the reason, over time, you're having less functional tissue. What does that mean for your digestion? Your digestion will be lower because you don't have as many enzymes being produced. So patients will often need to take digestive enzyme supplements. There's typically also going to be a good amount of pain that needs to be managed. And the last consideration is increased risk of pancreatic cancer. Now here's the tricksy part. Chronic inflammation can cause cancer. But guess what cancer causes? Chronic inflammation. So this is what we call a chicken and egg problem. So some patients have pancreatic cancer because they have chronic inflammation. And others will have chronic inflammation because of the cancer. So you can have spontaneous cancer that results in chronic pancreatitis, or you can have chronic pancreatitis that results in cancer. Either way, pancreatic cancer is one of the most deadly cancers that we know of. All right, any questions on pancreatitis? All right, let's take a 10-minute break, and then we will come back and talk about cancer.
I still think cancer is
This is our last lecture together. How do you feel about that?
Yep. That's so sad. Oh my god. That's so
And then you'll never have me again.
That is so sad. He's excited. He doesn't have to deal with us anymore. Oh my god. What was that?
What was what? That was how you guys feel. At first you're sad, and then you're like, yes! So, I know there's a fly around here. Who let the fly in? Serena? Was it you? All right. All right, so what we're going to do now is we're going to talk about cancer. So, sometimes when we talk about cancer, you will hear people talk about neoplasms, which comes from the word neoplasia. So, what we have to do first is talk about some adaptations and what the word neoplasia means. So, plasia means cell growth. And there's a number of adaptations that can occur to cells as a result of stressors. So one of them is hypertrophy. What does that mean? Growth in the size of a cell. So for example, if you work a muscle, the muscle cell will become bigger. That is known as hypertrophy. The opposite is atrophy. A reduction in the cell size. Now, if you have an increase in the number of cells, that is called a hyperplasia. So a classic example of that is BPH, benign prostatic hyperplasia, where you have an increase in the growth of prostate cells. Another classic example would be a callus. So you have an increase in the number of skin cells. But they're still normal skin cells. They're still normal prostate cells. There's just more of them.
And these are all types of neoplasia.
Yes. No. These are not types of neoplasia. These are normal adaptations to stress. Stressors. Just normal adaptations. Normal cellular adaptations. Now, we can go a step beyond that, which is not exactly normal, and that is a metaplasia. So that is when a cell differentiates into a different kind of cell than is normally expected at that place. Metaplasias, if uncorrected, can eventually become cancers. So we talked about metaplasia in the bronchi from smoking, and we talked about metaplasia of the esophagus from GERD. So Barrett's esophagus is a metaplasia. So it is not a cancer. It is an abnormal differentiation of a cell.
Can hyperplasia become cancer or not?
No. Okay, next we have what is called dysplasia. Dysplasia is unorganized cell growth. And this is a precursor to cancer. So when you do a pap smear, what they're looking for is dysplastic cervical cells. if you ever go to the dermatologist and they remove a mole that looks suspicious, what they're looking for is dysplastic cells, which are more likely to become melanoma. So, dysplasia is disorganized cell growth. If left uncorrected, it can progress to cancer, and a much higher risk of cancer than a metaplasia. The next step in this process is neoplasia. And the root neo means new. So it is a new kind of cell that has not existed in your body before. And that is cancer cell. Now, not every neoplasia is necessarily super harmful. So we typically are going to characterize neoplasms as either benign or malignant. I don't know why they don't call it malign or benignant, but hey, benign or malignant. So this is more of a spectrum than a yes or no. So there are certain characteristics that are more likely to be benign, and there are certain characteristics that are more likely to be malignant. So, the first one is it encapsulated or not? If the cells are confined to a capsule, it's less likely to be malignant. It's less likely to spread. One of the main hallmarks of a malignant cancer is the ability to invade. So it actually invades nearby tissue. Sometimes it'll look like it's eaten through nearby tissue. And what happens is it's replacing the nearby tissue with cancer cells. So when we say invasive cancer, that's what we mean. So benign cells, instead of invading, they push. Now that pushing can cause problems. It can cause compression of nearby tissue, it can cause necrosis of nearby tissue, but it's not going to invade the tissue. What that means is once you cut it out, it's gone. Whereas with invasive cancers, you can cut out the main tumor, but because there's individual cells that may have invaded nearby tissue, you never know if you got it all until later. Does that make sense? Okay. Another one is what's called differentiation. So benign tumors are more likely to be highly differentiated, which is that they're going to look very similar to the tissue that it came from. Whereas malignant are less likely to be differentiated. So lower differentiation, and sometimes they are almost completely undifferentiated, and that is known as anaplasia. So what is anaplasia? Very poorly differentiated. So sometimes these are described as being more fetal-like. So fetal cells have the potential to become almost anything, whereas an adult cell has to pretty much stay what it is, right? So sometimes cancer cells appear more fetal in the sense that they can become anything. Another hallmark of malignant versus benign is the ability to grow a blood supply. Not. I like that. Another characteristic of benign versus malignant is slow growing versus fast growing. Another one is a high mitotic index. Do you remember what that means? What is mitosis? So the reproduction or replication of a cell. So mitosis is when the cell is dividing, and a mitotic index is the percentage of cells in a tissue that are actively undergoing mitosis at any given time. So with a high mitotic index, almost the entire tumor is trying to replicate at the same time, whereas in a benign one, only a few of the cells are currently actively dividing. So that's the difference between a high and a low mitotic index. And then the last one is the ability to metastasize, or metastasis. And that's the ability to spread to distant tissues. So what's the difference between invasion and metastasis?
Doesn't it like eat the surrounding tissue?
Okay, so invasion is into nearby tissue, and metastasis is distant tissue. Yeah. All right, are there any that are listed on your slide that I missed?
So would this just be another knot?
Yeah, not. All right, so a little side note on the word tumor. Technically, the word tumor means any mass that is larger than 2 centimeters. However, in modern parlance, tumor refers to cancers. So even though it would be correct to label any mass that's larger than 2 centimeters as a tumor, including, say, for example, a cyst, like a skin cyst, you don't actually want to do that because it freaks people out. I have a tumor, I have cancer. Don't do that, even though technically you are correct in describing it as such. Does that make sense? All right. Okay, so when it comes to tumors, not all tumors are cancerous in the sense that they're malignant, even though it might still be a neoplasia. It might be benign because of these issues, in which case simple surgical removal is more than enough to fix the problem. And again, these are relative degrees. So you can have a cancer that is relatively benign, but if you let it go long enough, it'll do many or all of these things. But because it's relatively benign, if you catch it early enough, it acts as though it's benign. Does that make sense? So it's not just a yes, no, but it's a bit of a spectrum. All right, now as far as the way that we describe cancers, we typically describe cancers based on what's called staging. And there's different methods of staging different kinds of cancers. So I'm going to give you one that you need to know. And if you ever go into cancer stuff, you'll learn more. But the one that we're going to learn goes like this. Stage 1 it's local. Sometimes it's called carcinoma in situ, meaning that the cancer is just confined to the organ. Then number 2 is locally invasive. So it's invaded nearby tissue. Stage 3 is that it's in lymph nodes. And stage 4 is metastasis. So tell me what stage 4 is. What does that mean?
Spread into distant tissues.
Spread to distant tissues. So what are the 4 most common distant tissues to spread to? BBLL. Okay, I heard someone say brain, bones, liver, lungs. Now, make sure you get this right on the test. You have no idea how innovative people are in their ability to get this one wrong. You guys make up organs that start with B and L just to get BBLL.
The Lincolnheimer.
Yeah. Or, yeah. So, brain, bones, liver, lung. 4 most common spots to metastasize to. All right. The next thing is that some cancer, well, all cancers come from normal cells, right? So, what kind of cells do skin cancers come from? Skin. What kind of cells do liver cancer cells come from? Liver. And what kind of cells do breast cancers come from? Breast. So, what kind of cells do prostate cancers come from? Prostate cells. So, whatever that cell was, those cells sometimes produce certain enzymes that are exclusive to that kind of tissue. So, like in your heart, we know your heart was damaged when it leaks what kind of enzymes? Troponin, which is specific to cardiac muscle. Well, in your prostate cells produce a protein that is specific to the prostate, and that is called prostate-specific antigen, PSA. So a prostate cancer will usually produce that same protein. So you can screen for prostate cancers by looking for that protein. So elevated levels of PSA, protein-specific antigen, are indicative of a high chance of prostate cancer. Does that make sense? Now, if a person's got prostate cancer that's producing PSA, and you remove the prostate, and you got all of the cancer, what should happen to PSA levels? Should go down to 0, right? So you can use that PSA level to 1, screen for cancer, and 2, to know if you were able to surgically remove all of the cancer. So PSA is a cancer marker for prostate cancer. Does that make sense? So there are cancer markers for all different kinds of cancers. So for liver cancer, we use something called AFP, alpha fetoprotein. For ovarian cancer, it's like CA123, or is it CEA? I can never remember. So there's a number of different ones. For pheochromocytoma, it's going to be epinephrine. So what is the main use of cancer markers? Screen for cancer. Yeah. Yeah, and then depending on the type, you can tell if you got the entire cancer by does the level go back down to 0 after surgery. So that's what a cancer marker is. So now let's take a look at how we get cancers in the first place. So there are 6 hallmarks of cancer. In order to become a cancer, there's 6 characteristics that a cancer has to have. And the first one is the ability to self-propagate. Or self-signal growth. So as an example, does your bone marrow just produce red blood cells, or does it do it only when it's told? Only when it's told. And what organ tells it to do that? The kidneys, through the secretion of erythropoietin. Now, if you're going to have a bone marrow cancer, what does it have to gain the ability to do? To grow new red blood cells without the need for erythropoietin. Or it has to come up with the ability to secrete its own erythropoietin. Does that make sense? So either of those will work, but it's got to have the ability to grow either without it or to produce its own. So that's the first hallmark of cancer. The second is it has to avoid non-growth signals. It's got to be able to ignore a signal that says, hey, don't you think you should stop growing? Don't you think you've had enough to eat right now? Okay. The next one is it has to avoid apoptosis. What is apoptosis? Cell death. So when a cell gets to a certain age, it decides to commit suicide. And then also it's got to be able to avoid T cell induced apoptosis, where a T cell says, hey, you seem a little off. Maybe you should commit suicide. No, no thanks. It's got to be able to say no thank you. It has to be able to produce its own telomerase. Now, what is a telomere?
Of the cell?
Say that again?
Is that the cleaving of the cell?
Kind of. So when you make chromosomes out of chromatin, you bundle them up, and they're joined at the center by a what? Centromere. Right. Centromere. And then at the end, they're held together by a little cap called a telomere. So tele at the end, centro in the center. So the telomere holds it together at the end. And every time your cells undergo mitosis, you use up a little bit of the telomere until eventually you have no telomere left. Now, how many of you have seen commercials for, I'm in this age, but my genetic age is blah, blah, blah? Have you ever heard those commercials? My genetic age? Genetic age is based on the amount of telomere that you have left. And hard living depletes your telomeres earlier than usual.
What is hard living?
You tell me what hard living is.
Lots of stress.
Lots of stress, smoking, alcohol, lots of infections, staying up too late, not getting enough sleep. Yeah. Smoking. Yeah. Okay. Drugs. Sex, drugs, and rock and roll. So your cells kind of run out of telomere juice on average around 120 years old. So kind of there's a natural limit to the human ability to grow, to live at about 120, because that's when we run out of telomere. But cancer cells can often produce new telomere on their own because they have the enzyme telomerase, which is usually associated with fetal cells. So, how many of you have heard of HeLa cells? They're named after, is it Henrietta Lacks? Is that her name? The woman in the 30s who, she went in to the doctor, she had cervical cancer. He took some samples of her cervical cancer cells, and then those became highly used for human research cells because they just grow forever. So there's still HeLa cells that are all over the place. There was a scandal about 10 years ago where they discovered that a lot of the cell cultures that were in various labs had been infected with HeLa cells. I guess the cancer cells had invaded. And so they're like, you know, what does this mean for our findings? So, and there's a big thing because she didn't get any compensation for it and all this stuff.
Did she die?
Well, yeah, she died.
From the cancer?
I'm not sure if she died from the cancer or not. But anyway, there was a documentary that came out about a year or two ago about her life and all that. So, Henrietta Lacks. Whatever. All right, so what are the last two hallmarks of cancer? Angiogenesis, the ability to grow a new blood supply. Why is that important for cancer? Without a blood supply, the tumor can only get so big before the center becomes necrotic because it doesn't have enough resources to be able to grow, especially oxygen. So remember that cancers are highly mitotic, which means that they're using up a lot of energy in replicating. So they need a good blood supply to be able to continue to grow. All right, what's the last one? Say again? Tissue invasion. So these are the hallmarks of cancer. And what we're going to focus on is the first couple right here. Well, I guess this one too. All of our cells have the potential to become cancer cells. How do they actually become a cancer cell? What happens is you have mutations in the genes that control these things. Does that make sense? Mm-hmm. So there's a concept that we call a proto-oncogene. A proto-oncogene is a gene that is susceptible to mutation that can cause cancer. Once that cell has mutated to where it can become cancer, it's no longer a proto-oncogene, now it is an oncogene.
So once it's become cancer?
No, once it has mutated, so that it gives the ability to become cancer. So remember, you need all of these abilities to become cancerous. So it's not enough to just have one of them, you have to have all of the oncogenes together. Now, you can have those oncogenes occurring that you inherit, and you can have oncogenes that you get by yourself, new ones. So when you look at one of the most famous oncogenes, the BRCA1 and 2 genes for breast cancer, those are oncogenes that are transmitted from mother to daughter, right?
So if you look at those, is that how they tell, like, if you're more...
You're higher risk, because you already have an oncogene. So you don't need as many mutations to get to breast cancer, because you've inherited one of them already.
Got it.
Does that make sense?
Yeah.
Okay. So, see you at the test on Tuesday. Bye.
Hold on, let me double check. All right, you good.
All right. So the oncogenes are once the mutation that promotes cancer has been achieved in that proto-oncogene. Now, most of the time when a person gets cancer, they're having new mutations inside themselves. It's not that they inherited it from their parents. In order to be able to inherit cancer from parents, where does the mutation have to occur? In the gametes. So if you've got mutation in the gametes, that can lead to mutations that are inherited. But you can't, because if your mother gets new mutations in her own breast that leads to breast cancer, you are not going to inherit that risk because that happened in not reproductive cells. Does that make sense? Mm-hmm. So when it comes to inheriting cancer risk, yes, but. What's the but?
It has to be in it.
It has to be in the gamete, not in the tissue that gets the cancer. All right. So proto-oncogenes become oncogenes, and then those oncogenes, if you get enough of those accumulating in the same cell, eventually can become cancer. And there's 3 stages that we talk about. The first one is called the initiation stage. And in the initiation stage, that's when you're acquiring these mutations. Then there is the promotion stage. Is that right? What does it say on the slide?
Let's see.
Yeah, so in the promotion stage, what's happening is the cell that has those mutations is being promoted over other cells of the same tissue. So what you're ending up with is a whole collection of cells that have that oncogene present, those oncogenes present. Now, once you have a whole bunch of those cells that could become cancer, what's the chances that any one of them become cancer? Much higher. So the idea is that you start off with one cell that could become cancer. That cell becomes promoted so that you have hundreds or maybe even thousands of that particular cell. Now you've got thousands of chances for any one of those cells to become cancer. And then the last stage, what's it called?
Progression.
Progression. And that's where one of those progresses to cancer. So initiation, you're accumulating mutations. Promotion, the cells that have the mutations are promoted over normal cells. And then the final stage, progression, is where one or more of those cells progresses to become cancer. Now the interesting thing is that the mutations don't stop there. So at first, cancers are usually what they call monoclonal. What does that mean?
One of a kind.
So every cell in the tumor is the exact same kind of cell. But because of that mutation process that led to the cancer growth in the first place, that often continues. And so late stage cancers will often be polyclonal. So they're all, say, liver cancer cells, but they're different genetically speaking. What does that imply for the treatment of a late stage polyclonal cancer? It's harder to treat because it's got different genetics inside of it. A monoclonal is easier to treat because if you get the right treatment, it'll treat every cell in the tumor.
It's easier to treat it early.
One of the reasons why it's early treatment is better. All right, any questions about how we acquire the cancer? Now, what is the driving force behind the cancer development? It's an M word. Mutations. So, things that are pro-mutagenic can be carcinogenic. So, there's a giant long list in your notes. You don't have to memorize them all, you just need to be familiar with the list. But let's go over some of the big ones. Radiation, X-rays, gamma radiation, but even ultraviolet light radiation can cause cancer. Now, what does ultraviolet mean?
X from the sun.
All right, so what is violet?
Color.
That's a color. In the spectrum, which color is it? It's the last, right? What's the first? Red. So in your Roy G. Biv, okay, so red versus violet. What's the difference in terms of light? It's the wavelength or frequency. So red is low frequency or high wavelength. And violet is high frequency or short wavelength. So ultraviolet is even higher wavelength than violet. Does that make sense? Okay. What's a shorter wavelength than ultraviolet? X-rays.
X-rays.
X-rays. And what's even lower wavelength than X-rays? Gamma radiation, which is what turned the Hulk into the Incredible Hulk. But hey, that's another story. So now, as we go this direction, longer wavelength, what do we get? We get radio frequencies, RF. How many have ever heard of RF? How's your cell phone work?
Same thing.
Radio frequencies. How does a radio work? Radio frequencies. Okay. One of the theories, how many of you have heard that this little guy here can cause cancer? That's why you should always keep it in your pocket, right next to your gametes. That's why you should hold it up to your head when you talk, so that you can get cancer. How many of you have heard of that?
Yeah.
Is it true?
No. We don't know.
All right, so here's the thing. When you expose mice to high levels of this, guess what? It causes cancer in those little mices. Does it cause cancer in humans? But you know what they said about radios back in the 20s and 30s? Don't sit too close to the radio, you'll get cancer. As it turns out, no, you don't. Yeah. So, but Ultraviolet light, we know, can cause cancer, and so can the other higher wavelengths. So radiation can cause cancer. Infections can cause cancer. Name 3 infections that can lead to cancer.
Pancreatitis?
No, that's not an infection.
Oh, sorry.
Say again? Hepatitis. So hepatitis C, number 1 cause of liver cancer. Give me another one. HPV, human papillomavirus, number 1 cause of cervical cancer. Name one more. How about HIV? And as a bonus, Epstein-Barr virus. Yeah, mono can cause all sorts of weird stuff later in life. Oh yeah.
Everyone gets it though.
Yep. Not everyone.
I doubt it.
So anyway,
Like if you don't feel it, or even if you do.
no, Epstein-Barr,
It's in your
so mono you just,
format for your life. Right?
yeah, so mono, which is caused by Epstein-Barr virus, stays dormant in your cells for the rest of your life. So it can cause a number of problems later in life. Most people it doesn't, but it can. It's all about that healthy living. Yeah. Probably because if you worry about it, stress, by the way, can cause cancer. How many of you have heard of 3 Mile Island? What is it? There's a nuclear power plant in New York on an island called 3 Mile Island. And in the 70s, it melted down. And there was a radiation leak. After the radiation leak happened, cancer rates in the area went up. But guess what? The place where people got cancer was not correlated at all with the radiation exposure. So the conclusions that researchers came to is that worrying about the radiation was more likely to cause cancer than the amount of radiation that they had. So yeah, stress. Anyway, so all sorts of things can cause cancer. Be familiar with that list. If there's anything you don't understand on the list, speak now or forever hold your peace. I'll give you a good 20 seconds to look at it.
What kind of physical activity are you implying? Just anything
What do you mean?
physical? With environmental factors?
Environmental factors would be things like sun exposure or asbestos exposure.
Oh, okay.
What is an EMF?
EMF is electromotive forces. It's what ghosts leave behind when they haunt a place.
I did not understand a word you just said.
Never mind. Okay, so as electricity goes through a wire, what's happening is electrons are actually traveling down that wire. As that occurs, there's forces that are involved that force the electrons to go. It's called EMF, electromotive force. So that can actually be measured, and exposure to high EMF can cause cancer, or can cause mutations, which could lead to cancer. So,
Sleeping with your phone getting charged.
no. So EMFs, as opposed to, in relation to cancer, are primarily associated with being close to high voltage lines. So if you ever, like people who live close to high voltage lines sometimes complain about headaches and other things, and maybe they get cancer too. So again, a lot of these things are occurring in mice at extremely high levels of exposure. So just because it can cause cancer doesn't mean it will in humans. But EMFs are also, like if you ever watch those ghost chaser shows, there's high EMF levels here. It must be a spirit. Yeah. Or if you ever watch the show, Supernatural. I like Jensen Ackles, so anyway. Any other questions? Yeah, Jensen Ackles was in a show, Dark Angel, with, what's her name? Jessica Alba.
That's not the guy that's in Gilmore Girls, right? That's his sidekick.
I've never watched Gilmore Girls, so I couldn't tell you.
That's supernatural.
Isn't the guy from Gilmore Girls Dean?
Dean.
Dean.
Yeah, I've never watched Gilmore Girls, so I don't know.
He's dreamy.
So in, they killed his character in the very first episode they had him in Dark Angel. So, but he was so charismatic that they had to bring him back as a twin, a clone. So, And I thought I liked Jessica Alba, but it turns out I just liked her character in that show. And I've never really liked anything else she's done. C'est la vie. All right, back to our story. So any other question, any other terminologies there that you don't understand? All right, let's move on then. All right, so once a person gets cancer, what happens to them? And there's a number of things that happen. So interactions between the host and the cancer. The first one is cosmetic. In the case of skin cancer, it's pretty obvious because you get a sore, a lesion on your skin. But in the case of other cancers, you can have changes in the contour of the body. So, for example, you can have dimpling of the skin, or you could have a bump or a lump. Cancers are also associated with inflammation, which can cause a number of things from increased clotting. Can also cause decreased appetite. And that's actually what leads to wasting in cancer, is the decreased appetite. That's what you can use dronabinol or medical marijuana for. Also causes increased metabolic activity. So not only are you having less appetite, but you're also using more energy because your cancer cells are highly active and you've got inflammatory processes, which also uses a lot of energy. So that kind of combination of increased metabolic rate with the decreased appetite is what ultimately leads to muscle weight, or just wasting away in cancer. What's the fancy word for that? Cachexia. For wasting away is cachexia. No, atrophy is reduction in size of a tissue. So muscles atrophy, but the entire body cachexes. Yeah. All right. So, and remember back to our vocabulary. So you don't say, "Oh my gosh, that person looks so anorexic." You say, "Oh my gosh, that person looks so cachectic."
Cachexic.
Cachexic. Cachectic. Yeah, cachectic.
Oh,
Yeah, that's great. So cachexia, cachectic, CH. So in the adjective, you turn the X to CH. So anorexia is loss of appetite. And that can occur in a number of things, including an eating disorder called anorexia nervosa. Also happens in cancer, also happens temporarily in certain illnesses like the flu, highly associated with inflammation. The cachexia is the wasting away of tissue and body because of the anorexia. Does that make sense? All right. What else in terms of interactions with the person? You also have a decrease in function of the affected tissues. So if they have pancreatic cancer, the pancreas is not going to work as well. If they have liver cancer, the liver is not going to work as well. And then we also have pain. And pain is an interesting phenomenon. Sometimes the pain is associated with the location of the cancer. So for example, if you have bone cancers, your bones will typically hurt. But sometimes it's not associated with the location of the tumor. Sometimes you just have pain. And a large portion of that is because of inflammatory processes that in turn are changing the perception in the brain. So remember that inflammation helps to upregulate nociceptors. And then at the same time, you also have probably a bit of depression going along with your cancer, and then that increases pain perception in the brain. Now, as far as treatment goes, the main way that we try and treat patients is going to be, number one, surgery. Surgeries can be either curative or palliative? What is the difference?
It'll completely cure, if once removing the entire tumor, it'll cure the patient, but palliative, it's kind of like a temporary maybe solution. I don't know.
All right, so in curative, the goal is to cure the cancer by removing it. It doesn't always work, but that's the goal. In a palliative, we don't expect to cure the cancer. We don't expect to remove it all. What we expect to do is reduce the size of it, which will hopefully have a number of positive effects on the patient. Okay, the next thing we can do is radiation therapy. Radiation therapy can be targeted, so it can be targeted at specific tissues, and that can be from an external source or an internal source. So an external source would be like an X-ray, where they aim a beam of radiation at the affected part. An internal source, an example of that would be radiation therapy for iodine. So radioiodine, the iodine accumulates in the thyroid, killing part of the thyroid. Does that make sense? They can also do internal radiation that is like surgically implanted. So basically they have like little either plastic or glass beads of some kind that are impregnated with the radioactive substance. They implant those in the area where the cancer is, and then they can remove them at a later date or leave them in permanently. So those would be from an internal source. The next thing we can do is we can do chemotherapy. So chemotherapy is usually going to be aimed at targeting fast-growing cells. Remember that one of the hallmarks of cancer is fast-growing and high mitotic index. So by targeting fast-growing cells, you're going to target the cancer cells. What's the problem with that strategy? You kill other fast-growing cells, such as hair follicles, skin lesions, mouth lesions. You might have trouble growing enough red blood cells or white blood cells. So aplastic anemia is a potential adverse effect. And if you've got low platelets, that can lead to bleeding. If you got low white blood cells, that can lead to infection. And if you have low red blood cells, that leads to feeling tired, pallor, lightheaded, and dyspnea on exertion. 4 classic signs and symptoms of anemia. I'm sure you remember all that from test 5 last semester.
Lightheadedness and dyspnea on exertion.
Yeah, I remember all that, sure. Okay. Chemotherapy also usually has nausea as an adverse effect. A lot of chemotherapy drugs can directly stimulate the chemotrigger zone in the brain, which is why they cause nausea. And we learned about antiemetics last class, so we're not going to reiterate all that.
So would you suggest and then a serotonin receptor? Like if there's a question on it, would it be a serotonin? Because that's the best.
What do you think?
Yeah.
Yeah, I would predose with a serotonin antagonist, such as
Oh, antagonist, sorry.
ondansetron or Zofran. So most chemotherapy is cytotoxic. Kills fast-growing cells. In fact, some of the immunosuppressants that you can give are also chemotherapy drugs. So, for example, methotrexate. It's an immunosuppressant that we use in rheumatoid arthritis, but it's also used in some cancers. Another example, or another type of chemotherapy is hormone therapy. So some cancers are sensitive to hormones. So breast cancer in particular is usually more sensitive to estrogen. Prostate cancer is more sensitive to testosterone. So by reducing the amount of testosterone available, you can inhibit the growth of prostate cancer. So some of the drugs will actually basically chemically neuter a man. got a fun little interview with a guy on my website about that. So it's this really big, tough guy who's like a wilderness survival instructor, like super manly man. And he got prostate cancer, and he was on a drug that basically inhibits testosterone. And he said, it's the weirdest thing. I have such an appreciation for my wife now and what it must be like to be a woman. He's like, the other day, it's like, I was driving my truck and I got a flat tire, and I just burst into tears. He goes, like, where did that come from? Oh, must have been the drug. And then I got over it and changed the tire. But it's like, these overwhelming sense of emotions is like, is that what it's like to be a woman all the time? So anyway, there you go.
Are these like Lupron shots?
Say again?
Are these like Lupron shots?
It depends. There's a variety of them. We're not going into any specific drugs right now. So some of the drugs are receptor inhibitors. So for example, like tamoxifen is an estrogen receptor inhibitor. So you can have hormonal therapy. And then we have a variety of immunotherapies.
Is it hormonal chemotherapy or hormonal therapy? Sorry.
It can be either. Some of them are surgical, some of them are chemotherapies.
Is immunotherapy its own class? Or is
Immunotherapy is its own thing.
okay.
Now, some of the immunotherapies take the form of drugs. Some of them are procedures. So, for example, one of the things that they can do is they'll take a sample of the cancer out. They will expose it to macrophages and T cells and try and sensitize T cells or dendritic cells against that cancer, then inject those sensitized cells back into you, with the idea being that now those sensitized cells will attack the cancer cells. Another thing you can do is called tumor painting, where they basically try and tag the cancer cells with something that your immune system will attack. And then once you attacked those painted cells, then you'll be sensitized to the other cancer cells as well. Those are just two examples of immunotherapy. There's a whole bunch of different kinds. So again, if you go into cancer treatment, you're going to learn all about these. But for our purposes, that's enough.
So do we need to know, like, effector cells and lymphocytes? Like, do we need to know all these on the cancer immunotherapy? Just,
No, those are just examples of things that are being developed and in treatment. So we've got to draw the line somewhere. We don't need to make you memorize everything. So in general, 4 basic treatments: surgery, radiation, chemotherapy, immunotherapy.
That's what we need.
Yeah. Within the chemotherapy, we can either target fast-growing cells or hormones.
Okay.
All right. One last thing to think about is the effect of the size of a tumor. So I've got this nice little chart in there somewhere, and it looks kind of like this. Right? Okay.
Yeah.
So it's size, or number of cells. Which one's on the bottom? Cell time.
And number of cancer cells is on the left.
Time and then number of cells, or size of the tumor. And so what you find is that there's a certain moment in time where there's enough cells, this thing is big enough for you to detect. The amount of time here is usually about 7 years. So on average, before the thing is big enough for you to detect, it's about 7 years have gone by. By that time, how many cells are present in that tumor? Go ahead and look at the chart.
1 billion.
1 billion. So by the time you can detect this tumor, there's 1 billion cancer cells. What are the chances that during those 7 years, one of those has gained the ability to metastasize and already has? Pretty big, right? I don't know. Now, one of the important things that this chart tells us is that the super emphasis that we have on screening and early treatment can sometimes be more harmful than good. So let's imagine for a moment that instead of catching it here, we were able to catch it there. So instead of 1 billion cells, there were only 500 million cells. Is that going to significantly increase your chances of survival?
No.
Probably not. But what if worrying about, we've already determined that worrying and stress can increase cancer risk, right? Yeah. Does being stressed out help improve your chances of fighting off cancer? Or does being calm and relaxed and living well improve your immune system? Right? Yeah. We know that stress decreases immune function. So, no matter how you cut it, is being stressed about, if only I had done my mammogram earlier, if only I'd done my whatever exam, if only I had, it might not have made any difference whatsoever. And chances are it wouldn't have. So, what we've found over the last 10 years is that a lot of the cancer screening recommendations have become less aggressive because what we were doing is mostly finding false positives. And then the stress over the false positives are, number one, stressful, number two, costly, because you got to do all this follow-up, and then number three, the stress of it itself might have caused cancer So what we were finding is that we were actually causing more harm than we were saving lives by catching cancer early. Does that make sense? So, on that note, any questions about cancer? Is there any slides that you want to ask me about that I have skipped over?
Are there like specific drugs that we need to know?
Are there specific drugs that you need to know? No. So, in general, what are the adverse effects associated with chemotherapy?
Wasting away.
Anemia, leukemia.
Right, so nausea, reduction in fast-growing cells, so alopecia, mouth sores, mucositis, low red blood cells, white blood cells, platelets. Yeah.
Can you talk about leukemia?
What is Oh, yeah. We do need to mention some leukemia things in specific. So, let's talk about leukemia real quick. What is leukemia, first of all? Cancers of the blood. And so we're going to separate them into two major forms: lymphocytic anemias, which come from the lymphocytic precursors, and then myelogenous, which come from the myelogenous precursors. So, what kinds of cells are going to be affected in a lymphocytic anemia? Lymphocytes, right, T cells, B cells. What types of cells can be affected with myelogenous? Red blood cells, macrophages, neutrophils, eosinophils, basophils, and platelets. To everything else.
So wait, what was lymphocyte was BMC?
Yeah. Now, in general, as your bone marrow gets taken over by the cancerous cells, it's going to crowd out the ability to produce the other cells. Does that make sense? So as you get more and more cancerous lymphocytic cells, there's going to be less room in your bone marrow to produce red blood cells and platelets and macrophages and eosinophils. And the other way around as well. Now these occur in two basic patterns in terms of time: acute and chronic. So you've got acute lymphocytic leukemia, and you've got chronic lymphocytic leukemia. And then you've got acute myelogenous and chronic myelogenous. When it comes to acute lymphocytic leukemia, this is the most common of all the leukemias. It's also the most famous because it happens in kids. But it's also the most curable. Now, CLL, AML, and CML all typically happen in adults. And the chronic ones are much, much harder to treat because by the time that they're diagnosed, it's really kind of too late. There's too much damage done.
What about AML?
So acute myelogenous leukemia is also hard to treat. It's particularly kind of deadly, but it happens in elderly folks as well. Now, when we say elderly, we're talking like 50s. Old for you guys. Young for the medical world.
Oh, so you mean actual like?
Yeah,
I'm gonna take out the elderly.
yeah. But older patients, not young adults and not kids.
So middle age.
Yeah. Yeah, as soon as you guys become working nurses, your definition of old is going to change dramatically. And you're like, he's kind of young. He's in his 50s. Because everyone in the hospital is like 70, especially here in South Florida. So anyway, that's really about all we need to know for the leukemias themselves. And then we also need to mention myeloma. So myeloma is cancer of a plasma cell. What is a plasma cell?
B-cell?
It's a fully mature B cell. What should a fully mature B cell do?
Make antibodies?
Make antibodies. So what does myeloma do?
Make antibodies?
It makes antibodies. But are they good functional antibodies? Are they high affinity or are they crap junk? They're crap junk. So you've got enormous amounts of protein floating around in your blood. So if you're looking at a cancer marker, what cancer marker would you look at? Total protein. So if your total protein is high, which is one of your liver function tests, by the way, but you've got normal albumin, well, where's all that extra protein coming from? Well, maybe it's rhabdomyolysis, but in this case, where is it coming from? Myeloma antibodies. Now, all of those antibodies have the potential to clog up your kidneys. Is that a good thing? No. So one of the things we may need to do for these patients is reduce the amount of protein in their blood. The way we do that is called plasmapheresis. Where did we learn about that?
For rhabdo? No, we learned about it, and you can do plasmapheresis for, is it one of the diseases we learned about for test 1?
I don't know about that. Test 1 was psych and neuro. Yeah, anyway. Yeah, you can use plasmapheresis for rhabdo, for those of you who said rhabdo. So, we can use plasmapheresis to reduce the amount of total protein, but realize the patient is going to be at risk for increased risk of infection. Increased risk, yeah. They'll be at increased risk of infection because they don't have good functioning plasma cells. They've got enormous amounts of junk antibodies. Oh yeah, Guillain-Barré plasmapheresis can be used for that.
Said it the wrong way, but.
Okay. The other thing about myeloma is that the plasma cells are going to live in your bone. So where is this cancer taking place? In the bone. So it can become particularly painful to your bones. The treatment, the ultimate cure for myeloma, is going to be a bone marrow transplant. So myelomas are particularly unpleasant cancers with a fairly high death rate. All right, any other questions that you got before we are done? Now, you can't come to me next week and say, Dr. Heyman, you missed this slide. Tell me about celiac disease, because there won't be a next week.
Don't worry, I'll email you.
All right.
Yeah, we'll send you
Is that
some
kind of all we
emails.
need to know for
Like cancer, because there's a lot.
leukemias?
Yes.
Just
Yep.
stuff, not like really in depth.
No, not really in depth.
So like when we're going over the PowerPoints, like what we hit is what we need to know, even
Yep.
though there's a lot more on the PowerPoint. Okay.
Yeah.
Thank you.
All right. See you guys on Tuesday.
1:30?
No, our test.
Oh, you'll get back.
Yeah, sorry. 1:30 for the test. And if you guys want to go to PDQ with the Patho Pharm 1 people, PDQ will be about, I think we said 11:30.
I'll be studying.